Hello and welcome to this video which accompanies the 2020 version of the UK Vessel Health and Preservation Framework. My name is Tim Jackson and I'm an anaesthetist with an interest in vascular access. I've been part of the working group that has been developing the UK approach to VHP over the last decade. I'm also the Vice Chair of NEVAS. Vascular access is the commonest invasive procedure in modern healthcare, and the impact of poor choice of device can be devastating, both in terms of the patient experience but also in terms of failure of treatment success. The concept of VHP is an internationally recognised approach to choosing the optimum vascular access device for a given patient in order to maximise the benefit of such a device and minimise complications, thus promoting the future viability of the vessels. Every choice within the patient's vascular access counts. I'm pleased to have this opportunity to present the second version of the UK framework to you. For those of you who were familiar with the original version, this one has been revised in response to developments in the literature, but also in response to feedback and evaluation of the original version in use. As far as possible, we have always striven to make the framework as inclusive as possible. We know that there is an awful lot of great work going on around the UK to drive forward the practice of vascular access, and as such, this framework is not intended to replace what works well in your local organisation. Nevertheless, what we have heard is that the framework is universally well received by experienced vascular access teams, and we hope that no matter how well evolved your service already is, you will find something in the framework to adapt to your needs. And so, without further ado, on to the framework itself. We have always provided the graphic in poster format, which this video is intended to explain, but there is also a handy pocket-sized leaflet, and this year we are also excited to announce that there will be an app as well. I'm going to take you through the series of questions and assessments that you will need to follow in order to assess your patient's optimum vascular access device to fulfill their needs. The first and arguably most important consideration remains: is vascular access actually necessary? You may think this is superfluous, but IV therapy is taken for granted in many circumstances, so that alternatives have not been considered, and we feel it is important to remind the user to pause and evaluate their options. Once we have confirmed that an IV route is indeed appropriate, we move into the right line decision tool. Here we find an initial division into whether the patient has an emergency or non-emergency need for IV access. In a genuine emergency, the priority is to achieve vascular access by the quickest and most reliable means available. This will usually result in a peripheral IV cannula being sited. Should it be impossible to achieve peripheral IV access in a timely manner, then other alternatives are described. You should bear in mind that you may need to call for help of your local vascular access expert in such a circumstance. We do not specify who that should be, as we are well aware that different organisations have differing services available. We also acknowledge the work done by Van Loon and others to describe difficult IV access, or DIVA as it's now known, pathways for patients who are known to present their own challenges to any clinician attempting to achieve IV access. The key here is to involve your vascular access specialist early in the care of the patient. We recommend that such DIVA patients have a bespoke vascular access pathway designed for them. Most patients will require vascular access in a non-emergency setting, and this is where the Right Line Decision tool offers evidence-based advice as to which device to choose. In simple terms, there are three factors to consider when making vascular access choices: the nature of the therapy itself, the expected duration of that therapy, and the status of the patient's venous anatomy. Firstly, we refer to the information on suitability of medicines for peripheral IV administration. Here we have made some changes. Those who are familiar with the first version of the framework will recall a sample drugs list which gave examples of drugs and their suitability for peripheral IV administration. We acknowledge that there has been an evolution of the understanding of the physical characteristics of drugs and the impact of this on the health of small veins. As such, we no longer offer a list of drugs, as the key principle is that all drugs can be harmful to fragile veins. A prescriptive list could offer false reassurance. Our advice is to be familiar with the drugs and therapies which are in common usage in your clinical area and decide accordingly. Naturally, there will be some drugs which should unequivocally be administered via a central venous access device or CVAD, such as certain cancer chemotherapy or critical care infusions, and we would expect specialist practitioners to be familiar with such agents. We have worked closely with colleagues from Medusa, the online injectable medicines guide, and this provides an excellent resource to guide decisions on specific medicines with which you may be unfamiliar. Having considered the risks posed by a particular drug to vessel health, you can then follow the tool towards the central or peripheral vein route. If you have chosen a centrally placed device as being your most appropriate solution, the next step is to decide which device is the most appropriate for the intended duration of therapy. Here again we have acknowledged developments in the literature, most notably the MAGIC group led by Vineet Chopra, and have offered solutions including non-tunneled CVC, PICC and tunneled CVC or implanted port. Clearly, the availability of each of these devices will also depend on which services are available in your organisation. Returning to the central versus peripheral decision, we will now consider how to decide the appropriate device peripherally. Here we refer to the vein assessment tool. This grades the number and quality of available veins and thus suggests their viability as a successful route for securing peripheral access over the intended course of treatment. As many patients will tell you, this is not just about how easy a vein is to cannulate here and now, it's also about how long that peripheral cannula will survive. This is where a thorough assessment of available veins will also guide the choice of the optimum vein in which to insert the chosen device. You can see that there are suggestions for the management of the IV access of both an inpatient and an outpatient setting, and this also acknowledges developments in vascular access where there are now many more options for extended dwell peripheral IV cannulae available on the market. The final consideration for peripheral vein access is that even for drugs which are deemed suitable for peripheral IV administration, when used over longer courses of treatment, they may fall outside our recommendations. In such cases, it is important to consider whether an alternative device would be sensible, and the tool directs you back to the choices for CVADs. What we have described here is the influence that the basic information of drug, duration of therapy, and health of the patient's veins has on vascular access choices. We also set out several secondary considerations, which may modify the choice taken. For example, patient preference based on prior experience or other patient factors. Although these do not form part of the earlier stages of the right-line decision tool, they are arguably the most important aspects to consider for an individual patient, as they will influence the success or failure of any device that is used. The final element of the framework describes how an approach to daily evaluation of a vascular access device can have an impact on future device choices. Although what we have described up until this point is an evidence-based approach which is appropriate for patients in general, it will not be right for every patient every time. And it is vital that early recognition of problems with a particular device should prompt re-evaluation of whether that device is right for your patient, or whether it is appropriate to choose a different device in light of the complications experienced. In practice, the commonest scenario will be escalation to a CVAD from a peripheral IV, but other choices are available, and every choice matters for the future health of the patient's veins, and hence the future success in IV therapy. This section of the tool also takes into account that if new diagnostic information comes to light, for example confirmed microbiological culture that indicates a change of antibiotic therapy or duration of treatment, this should prompt a pause to consider whether the existing vascular access device remains the ideal choice. Similarly, if a patient becomes well enough to be discharged home on IV therapy, this may also prompt a re-evaluation. I hope this video has helped to increase your understanding of the VHP framework. Please remember that the best way to consider adopting this is to adapt it to your area of practice. Try to evaluate what already works well in your service and what you feel is ripe for improvement. Ask yourself whether a VHP approach could be adapted to improve the IV therapy experience of your patients, and above all, remember that every choice matters. Thank you.